Okay, so let's dive into radiologic evaluation of the shoulder. As we move through the upper extremity, what I want you guys to get a good appreciation for is the similarities that we see upper extremity versus lower extremity and some of the differences. So we're going to see a lot of things that are the same, and we're going to see a lot of things that are vastly, vastly different. So when we look at the three main modalities for imaging of the shoulder, we're going to look at radiographs, CT scan, and MRI. A close fourth is going to be diagnostic ultrasound. The shoulder is going to be one of those areas where we have a lot of superficial structures, and diagnostic ultrasound can be very beneficial and very useful. In looking at Riemann's text, again, and we kind of covered this with the knee, kind of covered this with the foot and ankle. Look at that reference standard. That reference standard for the vast majority of your rotator cuff injuries is going to be surgery. So again, this is why your patients are going to so often come in and say, oh, the doctor went in there and he found so much more than the MRI did. Look at the sensitivity and specificity numbers. Some of them are okay. Some of them are just flat out not very good. I'll be perfectly honest with you. Even for a full thickness rotator cuff tear, when the diagnostic ultrasound or diagnostic test was an MRA or a CT, still we only had 95%. That means that 5% went undetected. That's not real good. So just remember that reference standard is always going to be literally getting a full and direct view of that structure. Looking at other pathologies that can happen in the shoulder, again, our reference standard is pretty much going to be surgery. The exception to that is going to be the AC joint arthropathy. We're going to look at an injection of the AC joint or an aspiration of the AC joint specifically, but then you look at the sensitivity and specificity numbers for that. It's not great versus a radiograph. There's not a lot of correlation there. So, again, this is really why we need to be proactive. This is really why we need to be good communicators, because even if that patient comes in to our office after accessing either primary care, an orthopedic surgeon, a specialist, fill in the blank, and they had a diagnostic image, we really need to be proactive if that patient's not progressing or that patient's showing signs and symptoms of a potential rotator cuff or shoulder pathology. So what I want you to do now is I want you to pause the PowerPoint slideshow and I want you to really think about how you would view each of these structures. Go back to anatomy. Think about where the surgical neck is on the humerus. Think about where the anatomic neck is. Greater tuberosity, lesser tuberosity. So looking at, this is a nice little review of anatomy of the posterior aspect of the shoulder. Just understand and realize what muscles are going to lie superior to the spine and the scapula, what muscles lie inferior. Obviously, this is kind of a basic overview of our anatomy. And then realize as well where those other structures are going to lie. Because when we start getting into especially diagnostic ultrasound, we're going to start looking at these structures and we have to have a really good and in-depth knowledge of anatomy, because what we're going to see is that the picture doesn't look this pretty. It never actually looks this pretty, especially on an ultrasound. Looking at the anterior aspect of the shoulder, big things to note here. Think back to anatomy, your course in your first year of PT school. Think about what attaches to that lesser tuberosity, what attaches to the greater tuberosity, where that bicep tendon lies, and then things like latissimus dorsi. Think about where it attaches to the humerus. Think about where pec minor attaches to the scapula. Think about where muscles like teres minor attach. So really take it back to that level of anatomy, because as we start getting into the detailed radiographic views, we're going to have to know where everything attaches in order to accurately diagnose. So there's our biceps tendon. That's what we're really going to note here. Biceps tendon is notorious for fraying and tearing, but also realize and understand where that biceps tendon attaches. Now what we see here is we only see the long head of the biceps. Please realize that the short head of the biceps tendon is going to attach to the coracoid process. So we have to understand that our long head is going to attach at the superior aspect of the glenoid fossa. There's our rotator cuff. So just realize where the rotator cuff lies, what muscles comprise the rotator cuff. Also realize all those distal and proximal attachment points. So getting into the actual imaging. When our patient is going to have an AP image, this position specifically is an externally rotated shoulder AP view. So my shoulder is positioned in external rotation, and my radiograph, my x-ray beam, is being shot anterior to posterior. This is very important to know because if we know what position that person is in and we know what structures can be seen on that position, we're going to have a very good guess on what we're looking at. So this is what we're going to see. This is a nice actual sketch of an AP view of a shoulder. So think about what muscles attached there. Think about what you would see if there's a pathology that's present. Where would a fracture be? How would it look on this sort of x-ray? Would we be able to see all pathologies in this view, or would we need other views? So taking a look at this schematic, this is obviously a much more detailed view. Look at the coracoid process. We have a pretty good view of that. Pretty good view as well of the spine and the scapula, even though it sits on the posterior aspect of the human body. Also realize that we can see greater tuberosity, lesser tuberosity, a little bit. We actually see a little bit of a white area where that lesser tuberosity is. But what I really want you to do here is be able to label a view like this. So if you saw this view on an exam, you'd be able to label all those pieces and parts. And obviously don't forget the lung, because the lung is a very important aspect as well. This is an AP internal rotated view. So again, radiograph is shot anterior to posterior, but my shoulder is placed in internal rotation. Again, what I want you to do is I want you to pause the video and I want you to think, what can I see? What can't I see? And I want you to compare the internal rotated view versus the external rotated view. So what this internally rotated view really does and why we're going to use it is that lesser tuberosity is much better visualized. The reason it's much better visualized, with the externally rotated view, there's a lot of attenuation. So we really don't get a good view of the lesser tuberosity. If we internally rotate the shoulder, then even though the lesser tuberosity is moving more towards the glenoid fossa, we actually can get less attenuation and we actually can see it. And that's very important because of things like avulsion fractures. If our patient has potentially an avulsion fracture happening at that lesser tuberosity, we need to know those things. So again, here's a nice detailed view of an AP radiograph in internal rotation. So again, we can really see the lesser tuberosity here, more so than when we're in an externally rotated view. And as always, don't forget the lung. Now, AC joint's a special joint. When we suspect that we have a separated shoulder or we have a AC joint that may be ruptured or compromised, what we're going to do is we're actually going to place the patient standing in the anatomic position without weights, and then we're going to put literally 2 10-pound sandbags, one in each hand. And what that's going to do is that's going to provide a distal traction force at the humerus. If you think about it, if my AC joints are intact, then I should see the clavicle travel distal as well, right? Because it's all going to travel as one big unit because it has that continuous AC joint linking those two bones together, the clavicle and the scapula. If I have a ruptured or I have a very lax AC joint, then I'm literally going to see that clavicle not ride with the scapula. It's not going to move distally or move inferiorly with the scapula. These are normal. So what should happen is we shouldn't see much of a difference between a weighted view and a non-weighted view when it comes to the AC joint. Again, with the weighted view, here's all the anatomy we can see. So we can still see a lot of things. We can still see not just that AC joint. And I don't want you to think that we're only going to look at the AC joint here, because we can still see the acromion, we can still see coracoid process, we can still see a lot of stuff. But realize that the weighted view for the AC joint is skewed towards viewing that AC joint, but it's not the only thing we can see. Here's position for an AP radiograph of the scapula. What we're going to do here, and you really think about it, is we need to move that humerus and we need to move the radius and ulna out of the way. So if I want to specifically view that scapula, say my patient has a scapular fracture, or we potentially think maybe they have some sort of avulsion or something happening, I'm going to place that patient in 90 degrees of abduction, 90 degrees of external rotation. Then I'm going to shoot an AP radiograph because I can get a good portion of that scapula without any sort of other attenuation from a bone. This is what an AP radiograph is going to look like at the scapula. As you can see here, we see a lot of different structures. We can see a lot of portions. I mean, that glenoid comes out really nicely. Yeah, the humerus comes out really nicely. Acromion, clavicle come out really nicely as well. This is a lateral view for the scapula. Again, what we're going to do is we're going to place our patient side-lying, and we're going to shoot that x-ray in from lateral to medial, and this is exactly how it's going to be shot. It's not going to be the greatest view, but a lot of times what we need to see is we need to see different aspects of a bone. Remember, one view is no view. So just getting that AP view of the scapula a lot of times is not good enough. We're going to need another view at a 90-degree tangent. That's where this lateral view comes in really nicely. This is the imaging that we're going to see. This is going to be the structure that we see with the lateral view. So the big advantage here is I can see that entire body of the scapula. Realize though that there's going to be some attenuation. So what I'm going to see most is I'm definitely going to see not necessarily the lateral edge, but the medial edge. But if I had a fracture that came straight through the scapula, then I'll be able to see that.